So thank you, Mary. I appreciate that. All right. So we're going to go ahead and do laryngectomy then, since I can't pull up that video. But the first page that you have there just shows or goes over the anatomy of the larynx. And it is the upper extremity of the trachea. So you can see the front view and the back view, and then the side view of it on your picture. So if you remember back to when we talked about tracheal Malaysia, and see on the center picture where it's the posterior, see how those tracheal rings don't come clear around the back? So you can see how that dilatation is able to take place. So like I say, you can look at the pieces and parts there, but that's just on there for a little review for you. Okay, so what are the functions of the larynx? They are the airway between the trachea and the pharynx. They do have, or it does have, sphincteric action, so it prevents aspiration. It allows you to increase your interthoracic pressure, meaning it allows you to strain, like if you want to cough, lift, perform a Valsalva maneuver, something like that. There's a cough reflex that's triggered when objects touch the very sensitive laryngeal mucosa, and they'll start to cough or gag. It does help with phonation. Vibration of the vocal cords allows you to produce speech. And then it also helps by allowing moving up and down of the vocal cords, relaxing or firming the edges of the vocal cords, and changing in the length of the vocal cords. Remember that speech is also formed by your pharynx, palate, tongue, teeth, and lips. So it's a variety of things that allows that to occur. So you know, people that are lacking teeth and they kind of have a kind of mumbly type speech to them. People that are missing maybe a little bit of portion of their tongue due to some type of oral cancer. That all interferes with how well you can understand or how well they can articulate speech. Stressors related to laryngeal cancer. What does your book emphasize? Well, it talks about tobacco use. It talks about alcohol use, and the combination of alcohol and tobacco does increase the likelihood or the percentage that you could possibly get laryngeal cancer. They talk about people that have poor nutrition, but if you consume large portions of alcohol, we have talked about, or we will talk about next week, about how our folks that are suffering from alcoholism are oftentimes suffering from some type of malnutrition because they give up calories in order to consume, give up nutrition, proper foods in order to consume alcohol. HPV, human papilloma virus, has also been associated with folks that have laryngeal cancer. And then occupational pollutants or airborne carcinogens is also another one. One that I don't think is going to be on the slide. Yeah, another one that some of the books talk about are chronic voice strain. So some of our folks that make their living by singing, those kind of things, you'll hear that those folks occasionally will have to take time off to have a polyp or something removed from a vocal cord. That's just from continuous use and strain of their voice above and beyond what it was ever meant to do. So they will have like polypectomies, and then they'll have to go 6 months, sometimes to a year, of really not performing or utilizing their voice until that heals. So that could be another possible cause, would be voice strain. So how do we prevent that? You can see some statistics there on your paper. You can read those in occurrence. Well, we would want to decrease smoking, obviously, because it plays a high risk in it. We want to decrease alcohol intake, and especially the combination of the two. We want to decrease our exposure to carcinogens, inhaled carcinogens, pollutants, those kind of things. So OSHA has kind of helped with that in the workplace. And then decreasing voice abuse. and then voice use, especially with chronic laryngitis. And I think your book does talk about laryngitis in there. I'm not sure if I pulled that out of another resource, but again, that kind of goes in with that voice strain and abuse. And we know folks sometimes that if you get a little cold, they automatically get laryngitis. And over the years, it can take its toll on the larynx itself. And you could have some structural changes and some cellular changes due to that chronic inflammation. All right, so we do have some varying types of laryngeal cancer. And the first one is supraglottic or extrinsic. It involves the vocal cords, above the vocal cords, the false cords, and the epiglottis. So above the vocal cords, the false cords, and the epiglottis. Usually no real early warning symptoms. By the time that they discover a lump in the throat, there's usually some type of erosion through the mucosa, and that's why they get the burning with anything that would be acidic or drinking hot liquids. Usually means that the tumor has spread by that point. Metastasis is usually fairly quick and it involves both sides of the neck. And it accounts for 35% of laryngeal cancers. Our second type is here's supraglottic. You can see here that it's very abnormal. The vocal cord should be very smooth, and in this case it is not. So we're actually looking down onto the vocal cords, and this is actually above them, and where you're seeing the irregular growth here. The second type is glottic. It is the most common form of laryngeal cancer. It involves the true vocal cords. The earliest symptom that you see is a hoarseness or a muffled voice, so a change in their voice. If it persists greater than 2 weeks, if you have any kind of symptom, throat symptom, especially if you would be a smoker, you should seek out medical attention for it. They do metastasize very slowly because there's little lymphatic drainage from where these tumors arise from, and they account for 60%. And here you can see glottic. This is directly right on the vocal cord. See how nice and smooth it should be if we look at the one on the right side? And you can see the abnormal growth here. So when you have an EGD done, where they're putting the scope down into the esophagus, into the stomach, not only do they look there, but the physician will also take a snapshot of your vocal cords, because it's a good opportunity to look at that. And actually, they have been able to diagnose a few laryngeal cancers due to just having an EG done because of some type of gastric issue. So that's one picture that they always take, is they take a picture of your vocal cords. Then our last type is subglottic, which is fairly rare. It involves the portion below the vocal cords. and it accounts for only 5%. And these are often asymptomatic until the tumor has grown large enough to obstruct the airway. Okay. So, what are just some manifestations of laryngeal cancer? Well, hoarseness, change in their voice, painful swallowing, dyspnea, foul breath, palpable lump in the neck, and earache. They oftentimes will have pain that radiates up to their ear. Okay. So, what are some diagnostics that we can do? So, the first one is an indirect laryngeoscopy, and you'll see the picture there. They're using a mirror and a headlamp to actually look back to the back of the throat. Then you can see out to the right side, that would be having them do ah, e, and it changes the vocal cord position. If nothing happens, then it would be paralysis of both of the cords. In this, you can just see a picture here. He's kind of holding the tongue with a 4x4 in his hand, putting the light or the mirror back to the back of the throat, kind of like what the dentist uses. And then when he tilts the mirror down, he's able to look at the vocal cords. Our next type of diagnostic evaluation is a direct laryngeoscopy. This is where the scope is passed to the larynx under a general or local anesthetic. The area is observed. They paint it with a dye, and the areas that take up the dye are considered to be abnormal or probably have some type of abnormal cells. This pinpoints the areas for the biopsy, and it's used for tumors above the true vocal cords. Postoperatively, because they've probably gotten some type of sedation, they're going to be NPO until their gag reflexes come back. How do you test that? Just you're looking at their ability to swallow or their ability to gag, and you can do that by giving them like a little ice chip or a little sip of water, or you can use a tongue depressor to the back of their throat, and if they gag, you know their gag reflex is back. If they don't, then you obviously know that that has not returned yet. Two to 8 hours. I need to change this. You know, if maybe you had a true sedation, possibly, but you're looking at more like maybe a 1 to 2 hour at the max before it comes back. So I would write 1 to 2 and don't put in the 8-hour piece. Okay, so 1 to 2 hours. We do vital signs every 15 minutes. That's due to conscious sedation. This is what the scope looks like. So you definitely probably want to be semi-out when they're doing that, because if not, they're going to be numbing the back of the throat either with a viscous lidocaine or acetylcholine spray. You want to watch for any respiratory difficulties, pain in their throat or chest, swelling in the throat or neck. Watch for apprehension. Sometimes those medications, although we think should sedate them, actually can make patients kind of goofy. And then watch for expectorating blood. There can be a little trauma to the mucosa, so you might have a hint of a little pinkish mucus for a few hours, but after that, they really should not have anything. And then provide for safety. Because they've had a sedation, they will be drowsy. We always say try some type of water first, like we said, an ice chip, something like that. I wouldn't give them milk or anything that could cause problems if they accidentally inhaled it or choked on it. And then remember, they have to have somebody drive them home due to the medications that they've been given. Some other diagnostic studies that they may have done would be soft tissue x-rays, barium studies like a CT scan, MRI, PET scan. Abnormal findings can include thickening or a deformity, irregularity of their mucous membrane, something that's fixated that normally should be moving in the laryngeal structures. And then what are our treatment plans? Well, that's determined by the staging of the cancer. So hopefully through those biopsies and the other things that they've done, diagnostic studies, they'll know what kind of treatment plan needs to be taken care of or done. The first one is radiation. It's often the choice of patients that have a very early or localized laryngeal cancer. So it's used for glottic or intrinsic cancer involving about one cord. The cure rate is fairly high, 80 to 90%. It's about the same as having a partial laryngectomy. It can be palliative in conjunction with chemotherapy. So they can actually put radiation seeds in it, like you would for a prostate. Okay, so they can embed seeds like you would for a prostate too. So it can be external beam or implanted radiation. It preserves the voice, although their tone can be affected, and they get it daily for up to 6 weeks. There's no weekend or holiday radiation programs open, so they would have those days off. Do remember that they're going to have to wait a while, usually 6 weeks after they've had surgery, due to the fact that we can pinpoint the area, but the area that's had radiation to it is damaged. And if we did surgery too early, we would not have proper healing. So we want to make sure that they can heal from their radiation before we want to do any type of surgeries. Some of the side effects, they can have sore throat, difficulty swallowing, dry mouth, hoarseness. And one of the things that you want to be aware of is that, oftentimes people will say, oh, I had chemotherapy, radiation will be a piece of cake. Radiation can cause scarring. Radiation can cause burns. I've seen radiation where it inflamed their esophagus so badly that they had to have a G-tube while they were getting radiation therapy because they couldn't even swallow their own spit. It was that painful. So, yeah, radiation seems like it should be a piece of cake, very easy peasy. It is not. Oftentimes it can cause quite a bit of trauma to the patient by itself. So just keep that in mind when somebody says that they have to have radiation treatments, that it's not always as easy as what it seems. I don't have a slide on chemotherapy, but for chemotherapy, they use a multi-drug approach. 5-FU or cisplatin is a couple of the medications that they use. It's often used to treat metastasis or for palliative treatment when the tumor is not resectable. just to make it more tolerable for them. Okay. So then our next possible thing could be some type of surgery. And the first one is laser surgery. This is done for a tumor that needs to be reduced or destroyed by laser beam. And they can do it via a laryngeoscope. And in the end, they will have a normal voice with some possible hoarseness. Our second type of possible surgery would be a transoral chordectomy. This would be due to a small lesion on one side of the cord that needs to be removed. In this case, they have a normal voice with no problems. It is resected via laryngeoscope. Remember, due to it going through the mouth, there is no skin incision. And there's a very high cure rate with it. Okay, so then this is showing you before the surgery, after the surgery, and then 2 years out. It looks like it did thicken maybe just a little bit or had a little bit of a change, but it's nice and smooth now. The tumor is gone. It looks actually pretty good. Okay, the third type, excuse me, is a partial laryngectomy. This is done for a localized tumor. About 50% of the larynx is removed. We remove the tumor and any surrounding tissue. They do get a temporary trach, and that's just due to edema and bleeding. And their trach, this is the discharge, isn't like discharge, but it's the trach will be discontinued after 2 to 3 days till we're sure they're not going to have excessive edema or any bleeding from the area. And they should be able to regain their full voice. Okay, so temporary trach, which can be discontinued in 2 to 3 days, they regain their full voice. So they'll have normal speech and airway after it's healed. Okay, there are a few risks associated with it, and you can just put it over underneath the far left column under types of surgery. The risks for this type of surgery are bleeding, aspiration, and subcutaneous emphysema, which remember that's the air underneath the subcu tissues, and infection. The subcu emphysema, remember, is the one that's going to feel like Rice Krispies underneath your fingers. And we'll talk about it more with chest surgeries, but that's what subcu emphysema feels like. Okay. The fourth type is a supraglottic or laryngeal laryngectomy. And in this one, we remove the epiglottis. We remove the hyoid bone, the false vocal cords, they will have a temporary trach for up to 1 week. They can have difficulty swallowing, and that's due to the removal of the epiglottis. There can be difficulty coughing or expectorating secretions. And they can have a tube feeding for 2 to 3 weeks. And this is so that they can get used to swallowing, go to speech therapy, relearn how to swallow, because now they don't have an epiglottis. So they're going to have to learn techniques so that they don't aspirate as they're eating and drinking. So the tube feeding allows everything to heal, allows them time to work with speech therapy and learn alternative swallowing and techniques and those kind of things so that they don't have a risk of aspiration. All right, and there's a couple risks. And the risks for the supraglottic is aspiration and possibly bleeding. Our last one is total laryngectomy on this page. And in this one, sorry, the title doesn't come up till later. We remove the larynx, the hyoid bone, the preepiglottic space, the strap muscles, 1 or more tracheal rings, and the pharyngeal opening is sutured shut. So this is a pretty extensive one for the total laryngectomy. So the entire larynx, the hyoid, the preepiglottic space, the strap muscles, 1 or more tracheal rings, and then the pharyngeal opening is sutured shut. They do have a permanent trach. They have a loss of normal speech and airway. There is a change in smell because you can't suck air in through your nose or mouth. They will have a temporary drainage tube just to reduce the amount of fluid that builds up behind that surgical line or incision. And then risks for this one. There is no risk of aspiration because we've sutured that pharyngeal opening closed. There's an increased risk of bleeding. There's a risk of a tracheal esophageal fistula and respiratory tract infection. And that's due to the lack of warming, filtration, all of those things that come with this particular type of surgery. Sorry, Danielle, what was the voice quality after a supraglottic laryngectomy? Normal voice, possibly a little bit of hoarseness. Once they've done any type of surgery on the vocal cord, the voice may never be 100%, but it would be pretty normal.
We can put you in one of those Absolutely not. Why not?
Okay, I got that person muted. All right, so those are the risks. So make sure you know no risk of aspiration when you do a total laryngectomy. So this is what it looks like. They do a surgical incision at the tracheal area. You can see that the larynx is taken out and they suture them shut. Then you can see here that here's your incision, here's your little drainage tube, and here's your laryngeal stoma. So that's what they look like. Here's when we talk about having the pharyngeal area sutured shut. Here's what our normal breathing looks like right now. Here's what it looks like after this space has been sutured shut. The air can go in and out of their trachea, down into their lungs, and back out, but nothing circulates really in and out of their nose and mouth. This air here is pretty stagnant. Okay. All right, we'll do two more things here and then we'll take a quick break. A radical neck dissection. This is a surgical removal of the subcutaneous and soft tissue, the sternocleidomastoid muscle, plus others, the jugular vein, and the spinal accessory nerve. This can be done for any head or neck cancer where it involves multiple lymph nodes. So I don't want you to think that you have a radical neck just with laryngeal cancer. It could be done with other head or neck surgeries. But oftentimes, if there's multiple lymph nodes involved, they'll end up doing a radical neck along with their total laryngectomy. What are some possible problems? Shoulder droop, that's due to the spinal accessory nerve being severed. Drains that we'll have to manage, and possibly grafting material. They can take enough out of that neck area that oftentimes they'll have to have grafting, possibly muscle or tissue taken from the chest area. And I'll show you a picture of that here in just a few minutes. Okay, and then the last one, number 7. Oh, sorry, I should have make sure there's nothing else there. Need to check graft circulation. So if you've never worked with grafting patients, or you've never had anybody in your family or known anybody that's gotten a graft, you always have a donor site. So either we've shaved skin off of your thigh, your back, your butt, something like that, and we've put it to an area that needed skin, or we've cut out a piece of muscle and put a muscle flap someplace. There is not only the donor site to look at, but there is the grafting site. So when we have a grafting site, vasculature should reestablish itself within several hours. If not, there's no nutrition getting to the graft. Once that has established itself, you do need to check the graft, because if it turns dry looking, black, the graft really never gained any circulation and it is going to die. So they'll lose their graft. In other words, you need to remove it because it's never going to get healthy again. So it's just telling you that if they have a grafting site, you do need to look at where the graft goes, and then you need to also be able to assess the donor site. Risks with a radical neck would be airway obstruction, carotid artery rupture, because you've taken away all of the extra pieces and parts that normally are surrounding that to give it cushion. skin flap necrosis, that your skin flap or your muscle flap doesn't take and it dies. And then our last one, oh, here's what it looks like. So they're really from under the chin down to the clavicles. So normally for our laryngectomy patient, the surgical incision would stop probably right there, and then they would have a stoma here and just one drain. Here you can see that we went clear up underneath the chin. We're taking out all of these lymph nodes through here, plus a lot of extra pieces and parts. So if we take so much material out here and there's no tissue left, sometimes they'll take a muscle flap from the pectoralis muscle and put in the neck to give it some cushion. And here's a picture showing that. Our last type is number 7, is a modified radical neck dissection. And in this one, really only the lymph nodes are removed. So no additional tissue, vessels, anything like that, only the lymph nodes. So there's no really real additional risks with having a modified radical neck, except for the typical post-op things that we would need to watch for following a total laryngectomy or whatever surgery they had done to have their modified radical neck. Okay, on that note, I'm going to let you take 10 minutes, come back at 5 after, and then we will continue on, okay?